Hey, good morning, good afternoon, good day, good night, everyone. It's a pleasure to be here today with all of you. It's a great event that LGN is organizing, and I'm happy to be part of this on behalf of the Lean Institute Bulgaria. My name is Vasil Petrov, and I'm the managing director of the institute. I also have several people here talking and supporting the event from our institute. The topic that I'll be talking about is related to healthcare, and it is lean applied in a large Bulgarian hospital. I hope that it will be interesting for you. Do not expect to see a full-blown project. I would say that what I'm going to share with you today is more of a case study, right? I will give you the background of where we started, and you will see why I call this a case study. Basically, during the pandemic, in the very beginning, when it started, due to the high levels of uncertainty, we wanted to help the healthcare system, and we were looking for opportunities ourselves. And we didn't expect somebody from the Bulgarian hospitals to contact us and tell us that they need us. First of all, because the hospitals were very busy and they didn't kind of think about what type of support they need on one end. On the other hand, the awareness in the Bulgarian healthcare system related to lean is not there. And that is something that we also wanted to wake up, and the challenge was more to find somebody in the hospital, in one of the big hospitals in Bulgaria, to get our help. It probably sounds a little bit strange because usually you should not be avoiding help. But when you say you want to look at the processes and give some advice, sometimes you are not well understood. And when you talk about lean methods and thinking, and people have no idea what this is, they say, well, I don't have time for such things now, we're too busy. Probably this sounds familiar to many of you, and that's the case in many industries in Bulgaria still, unfortunately. Even though we see very positive trends in the last couple of years, hopefully also in the healthcare in the future. Hopefully we were able to set an example with this short, limited in time frame case study, just because of the results that we achieved, because of this like a SWOT type of analysis that we did for the hospital. So that being said, I'm going to start with a little bit of background. Let me share a couple of words about the hospital and the situation. So we saw this was back in April, at the end of April, I believe it was last year, and lots of cases were increasing. We were talking about the personal protection equipment. Do we have enough? Do we know how to treat the disease? Do we know what process to follow? There was so much controversial information flying to the people. Even in the hospitals, if you would go to different hospitals in Bulgaria, you would see different doctors approaching the COVID, the virus, in different ways, giving different types of advice. And we knew that while we were approaching the hospital, and that's why we said, well, we need to see, do we need consistency? Is there consistency? Is there understanding of what needs to be done among the different people that are involved in the COVID triage department? And that was our focus. I'm going to talk about triage just in a few minutes. Well, the hospital, of course, this is a very big, probably the most famous hospital in Bulgaria, I would say. So the hospital was aware of the tough situation, and they started doing some changes. They completely changed the admission process for the patients coming in, just more of them to be examined at the entrance when they have some symptoms. Of course, they didn't want to. They were testing the temperature of everyone, but they could not test every single person in detail. So if there was only some sort of complaint, they would approach this person with more attention. And of course, there was the process of what happens if we have some doubts that this person might be sick, and we wait for the results of the test. If this person is confirmed sick, and what other complaints does the person have, and how should we treat this person? So there were different areas in the hospital that were already dedicated for this. So in terms of process, there was something in place, and that was very different from the traditional process. And that was great news. I mean, when we went there, we didn't know what to expect, and we saw that the people were adapting very quickly. And so they were kind of running their own PDCA cycle, if you wish. They were trying to experiment in order to find the best way to approach the virus. Now, what we were concerned with is what will happen if the numbers continue to increase. With the process that was existing at that point of time, would the hospital be able to deal with the patients that are coming in? The number of beds that are available, the number of people that can go through the triage department. So all those things we wanted to see, analyze, and then give feedback to the hospital with an action list that needs to be followed so that they can improve their process. And this was the first sentence that we heard when we said, so what is it that we can do for you? And the head of the emergency department said, I really would like to know if we are doing a good job. Because there was so much going on, and there was so much confusion, and there was so many tired people, people exhausted because of the risks out there, because of all the drama related to COVID, and we wanted somewhat also to help to boost the confidence of the hospital. And this is what I felt when I was talking to the head of the emergency department. And that was, by the way, that's a great person. That's the person that was so open-minded. This lady agreed, Dr. Dimitrova, to accept us. She had some good experience with consultants in the past, and that's why she said, "Wow, if you're offering help, we are very happy to get it." That's how we actually entered the hospital, and we said we're going to do it just in a few days, and we're going to show you what is the potential out there for you. And of course, the question that some of you are already asking yourselves is, how did we approach this? Because there are lots of processes in a hospital, and in order to understand the most of it in a very short time frame, we need to have a very structured approach. So we decided to focus on the triage department. The triage department is when the people are entering the hospital, they need to be pre-checked if they are sick or not sick, and then decide what to do, as I mentioned before. I'm going to give you a little bit more details about the triage room. But the approach, in order to understand the whole process around the triage, was the following. So how? We did interviews with the management to understand how they take decisions, how they adapt to the situation. We asked them questions related to the consistency of the process, to the information that they are getting and how they deal with it. Of course, we also talked to the doctors and nurses actually working in the triage department. Those are people that were so dedicated to the job. And I would say we really met some great experts in the area. It made me kind of feel very confident, very happy that we have such experts in our hospitals. And of course, another important thing apart from the interviews was shadowing the process from the perspective of a doctor and from the perspective of a patient, to understand how the doctor feels doing his or her job and how the patient feels when they enter the hospital. When we did it, we spent 1 day shift in the afternoon, 1 day shift in the early morning, and 1 night shift. The idea of that being was to see the transition between the shifts, how the people talk to each other, how the people exchange information, what type of information the people will be exchanging, the doctors, the nurses, related to patients that are currently in treatment, patients that are waiting outside. So there were many things that they had to share with each other in terms of process and people, and we wanted to know if this flows without disruption. You can see 3 shifts is not a lot of time. On the other hand, the findings that we have probably can be related to a period of months, right? Because we saw so many things, you will see, and we were able to actually monitor a lot of details in the processes, and the message that came to the hospital afterwards, we need to spend more time in that. We need to look at our processes more frequently, because if only looking at 3 shifts can deliver so many results, what will happen if we start monitoring our processes more closely on the long run. So what were the results from the analysis? First of all, planning and decision-making process. It was more of a spontaneous process, how the decisions were made. There were many good examples of other hospitals that were implementing some good measures, and this hospital was always looking for some good ideas. They were also discussing, the management of the hospital was discussing what can be done, and they were taking some decisions. But when something was not working, as I mentioned before, their PDCA cycle was running very quickly, so they were immediately adapting the process. If you see that something doesn't flow, let's change it. Now, this wasn't very structured, I would say, not the way probably a lean person would do it. It was more of a chaotic way, but still a way of adaptation to the new environment. So let me just open them up, all of them. So most of the decisions, as I said, were taken as a follow-up decision of the previous one. What struck us the most was that the communication of the decision was sometimes really poor, and some of the changes or most of the changes in the process were actually left at registration, which was supposed to share it with the different shifts on paper. And this wasn't a very smooth process, meaning that some of the shifts and some of the people were sometimes left with a very unclear expectation of what the job should be that they're doing. So if we can put it in lean terms, there was no standard work. And even though, we are talking about PDCAs and we are talking about changing the process frequently, but if you don't have a standard, you're actually changing in a chaos. And even though sometimes things are working, you cannot really understand what was it that you changed that made some of the processes work well. And this is what we're try to explain. There should be a standard of work, and then you have to plan the changes in the standard. And then you can see what happens. Then you have to adapt your cycle. So we were talking about this to the doctors, to the nurses, and we were talking about this to the management once we saw that those things are failing. And that was a big thing for us, right? When we looked at the triage room itself, now this is where a series of different steps were performed on a person that had some complaints related to the COVID. And not only that room was available for the triage, there were also 2 triagers in front of the building that were there just in case. If the numbers increase of sick people, those rooms could be used. Now, at the time of the analysis, the rooms were used for people to wait for their blood results. So basically, they were examined outside before they entered the building. Even though there was a triage department inside, which was actually supposed to take care of electrocardiogram and some other exams. Now, this was also mixed up. Our analysis showed that blood is taken everywhere, and people are questioned everywhere about their symptoms, outside, inside. Sometimes they are waiting inside, sometimes they're waiting outside. So again, the whole process of entering was not very smooth, and the process of examining was not smooth either. The process of talking to the people about their symptoms was also very unclear because several people were involved. There was a security guy talking, asking some questions, and then sharing the information with the doctors who's outside and what they're waiting for. Excuse me. There was also a policeman, so there were several people that were somehow involved, and they were trying to help. They had good intentions, obviously, but there was no structure in that. So sometimes one person waiting had to repeat the same thing to several people just to get some support, some help at some point. So the capacity was between, or actually the demand was anything between 10 and 50 patients. That was the max that they were able to process in 24 hours. And And there were some volunteers that were also trying to help in different ways in front of the triage room. But their main responsibility was to spray out the rooms, to disinfect, make sure that after every patient, the area is clean. Excuse me. The participants in the process. So those are the people that were involved. You can see it's not a excuse me, it's not a very simple process. So there was a policeman outside waiting at the entrance. There was a nurse involved in the triage, 2 security guys at the entrance as well, 2 people sitting at the registration next to the triage, 2 people at the x-ray, 2 people at the CT scanner, 2 volunteers to spray out and clean, disinfect, 1 medical doctor, and 2 people taking care of the medical, the blood tests. So 15 people altogether were part of this process, and those people, they had to work as a well-oiled machine, and this was not the case, unfortunately. The communication and like the lead time, which was defined by those 15 people, was totally disrupted, and we could see huge variations from I think it was from 2 hours or maybe a little bit less for a person to enter, up to 5 hours waiting, just because of several things happening at the same time, and the person cannot actually get any attention. So the process steps of this process at a high level are altogether 7. We're saying the patient arrives, and then the patient needs to register, share the symptoms. A rapid blood test was taken then, and then ECG is done, then X-ray is done, then if needed, computed tomography scan is performed as well, and then based on what was seen there from the results, a decision was taken. Does this person have to go home or go to another department, or needs to stay in the hospital for several days to be monitored before actually goes to another department? So that's a very simplified picture of the process, of course, and we didn't have the time to go into the value-adding activities in detail. We were more concerned in removing the waste in between them, and thus make the process much more efficient. So what you're seeing here is kind of a visual map of the place. Maybe if I can guide you through this, you can see here that the ambulances are coming in from this area. And those are the 2 entrances of the building, entrance 1 and entrance 2. And entrance 2 was locked. And entrance 1 was the main entrance where the people were entering the official route, and they had to measure their temperatures and then maybe go to the triage if there are some symptoms or complaints, or just go to the other part of the hospital if they have other type of problem and they have no temperature or any symptoms. So what we monitor here, and I will show you some statistic, is that people actually, not all of them did the temperature check for some reason. This was skipped as a step, and it was not controlled very well. And of course, something that probably you also see here is that the streams of the people that are coming sick and that are not sick are actually crossing. They're all coming through the same entrance. And one interesting that you can also see on this chart is here, the entrance 3 is blocked, and there was another entrance. So one of our recommendations, which was also taken very seriously, was to open this entrance so that we can split people that are coming for other complaints and people that are coming with COVID complaints, which stopped the crossing of streams of sick and not sick people. And that was, I think, a very important step that happened based on our recommendation. The areas that we split into 4 or 5 different categories were where the patients are met, the inspection at the entrance, the usage of both trailers, what's happening inside the triage room, and how the communication goes between the triage room and the CT scanner and X-ray departments. And as I mentioned, of course, the risk of crossing sick with healthy is something that we address as well. For all those areas, we put a lot of comments. I'm not going to go through them, but there was lots of things that we observed, and we just listed them for the hospital, saying those are things that you have to work on. You don't have coverage of the entrance area. You don't use the traverse efficiently. There is no consistency in the process. There are many issues also inside the triage room. There is lots of waiting caused by the other departments, and all those things we just shared and we talked about, and we proved with some of our statistics, so that the hospital can take this very seriously, and actually they did, which we're very happy about, and most of those problems were solved afterwards. Some of the statistics that we measured physically, this is not data that we took from any system. We were actually looking at the people coming in, the incoming flow, to see how many of the people would actually measure their temperature. And we saw that only 31% of the people would go inside without measuring their temperature, just because they knew the policeman, they knew the security, or the security was talking to somebody else, and at that point didn't notice somebody sneaking in just because this person wanted to go faster, or this person didn't know that they should get their temperature measured. So showing that statistic was like a wake-up call to the hospital, and the hospital realized that they should put more strict measures at the entrance, so that this percentage goes down to 0, because we cannot accept a person with temperature to enter the hospital. This person might be sick with COVID and might infect many other people inside afterwards. We created a draft of the value stream, and excuse me, some things here are still in Bulgarian, but like the main steps here from the patient perspective are registration, symptoms sharing, blood tests, ECG, X-ray and CT scanner. We kind of measured how much time is required for those steps to happen, saying those are the value adding steps, and there is a waiting in between. And we came to altogether about 30 minutes of time that should be sufficient for a patient to be treated or to be examined when they come to the hospital. Now, the reality is that the total time together with the waiting, and we took just, we monitored for 4 people fully, was 160 minutes. I think on average, even more, maybe in some cases. And here you can see of those 4 people, those patients, the value adding time and the waste time. So the waste is generally saying it's waiting. People are waiting. They are waiting outside to be examined. They are waiting afterwards to get inside. They are waiting in the triage department. They are waiting for blood tests. They are waiting for ECGs. They are waiting for X-rays. So in every step, there was some waiting time. And we explained the basic concept of flow in Lean to the hospital management and to the doctors. And how important it is to try to focus on one patient at a time to make sure that they will flow through the different departments. And we showed them how much more they can achieve if they start introducing some sort of a flow system in their work. So the waste analysis, of course, showed lots of waste, all of them. Probably most of the people listening to this now know the 8 wastes. We saw them all. On the overproduction, we could argue if there was overproduction, but most of them was there, and we gave them examples of the different types of wastes. And afterwards, when we gave them our recommendation, and then we asked if those recommendations are followed, we were basing this on the wastes as well. And last but not least, the actions that were taken. And here comes the part where I would say I'm very proud of my team, and I'm very also proud of the hospital team, because they took this very seriously. And last when I visited and last when I talked to them, they actually implemented almost everything that we talked about. I'll give you a quick glance at what was done. So at the entrance process, they introduced clear process for admitting the patients, which everyone was aware of. They also introduced clear roles and responsibilities at the new patient arrival, so that there was no security guys talking to the patients outside, or policemen, or the nurse going out to see what's happening. So there was always a clear process who needs to do what. Strict control in front of the trailers, so the security was actually responsible for the trailers, for the people to really wait in the trailers and not step outside because they say it's too warm and they want it's too small or whatever. They really, if they're sick, they have to wait inside and not talk to everyone else in the group of waiting people outside. And then there were some visual descriptions on every tray for the people to understand what the tray is for, and that they have to be inside and wait. The triage department was also improved. So the motion ways that we addressed with walking to the printer was provided for them, which saved them some time walking. There were some checklists for transferring the information that we introduced. We sent it to the hospital that they can use, and so those are the things that you have to share every time when you change the shift, so that everyone is aware of the current situation, and they can immediately take over easily with the other shift. And in the other related areas, what we call the X-ray and the CT scanner departments, we introduced, or the hospital introduced, an operational level agreement of 20 minutes, the most that should be waited for a result to come after a patient is examined. And usually it was much faster. And the other issue that was causing some delays was also the blood exams that were always pending, and the hospital staff had to constantly check if they're ready. What was introduced based on our recommendation, and it was an IT tweak, an auto notification that was sent to the triage department when the blood test is ready, so that they didn't have to check every time. They could immediately understand what the results are when they're done, and they could continue with the patient in the triage room. So those are the main things, and from what I understand, also some visual management is added or is being added as we speak inside the main entrance for the people to get a better idea of where they should go, because this was also one of our recommendations. So I hope this was interesting for you. Here are our contacts. You can, of course, always contact us if you have further questions whatsoever. And I hope that we have also several minutes now for some direct questions that you might have right now.
Thanks, Professor. That was fantastic. Thank you. We do have a couple of questions for you, actually. Let me just go into our chat here. Give me 1 second. Anelia has asked this of you. How did you manage to get the trust of the hospital staff for being an external person with no medical degree?
Yeah, well, as I mentioned, probably the key element here was that the head of the emergency department had some experience with consultants. So she didn't expect us to be medical people. She knew what to expect, and that was so much easier for us. She already trusted the expertise, the process expertise that we have, and she was actually extremely supportive of anything that we needed, all the information that we needed, all the people that we need to talk to. She was organizing everything immediately. So I guess the big thing here was the full management support and understanding of what we are there for.
Wonderful. And I think there was one more, actually. Did the hospital implement the suggested improvements that you made?
Yeah, as I mentioned on the last slide, everything was almost everything was implemented. I have to be honest, somewhat to my surprise, because we didn't know what to expect. We did our best. We did it because we wanted to help. We did it for free. We just went there and we spent nights and days. We're very committed to have something tangible, something that makes sense. We explained it in the best way possible, and we were hoping to see the changes coming in. And when I visited, I saw the changes already implemented. I talked to the emergency head, and she confirmed, and that she was very thankful. Yeah, everything goes pretty well now. And of course, there is much more work to be done. Hopefully, we'll be able to find them in the future. Yeah.
Wonderful. Well, I think that's all the questions we have. Everyone, thank you so much for a wonderful presentation, and thank you for joining us. We're nearly there. But I appreciate everyone being here, and I hope you enjoyed it. Thanks, Nilly, for your input too. Much appreciated, and enjoy the rest of the few hours that we have left.
Thank you, Lisa. Thank you, everyone.
Bye, everyone. Bye.